All right, it looks like a couple more people are joining, but it's slowed down quite a bit, so we can get started. My name is Victoria, and on behalf of the Education Work Group, we would like to thank you all for attending our September Lunch and Learn presentation on Socioeconomic Status as a Mediator of Overall Survival in Acute Myeloid Leukemia. A few housekeeping items before I introduce today's speaker. First, we will be recording today's presentation, which will be made available on the internet over the next few days. Second, everyone present here today will receive a certificate for their attendance. Today's presentation is eligible for 1 continuing education credit, which will be listed on your certificate. Third, we will have a short survey after we end for the day, so please take a few moments to fill that out. We would greatly appreciate your feedback on today's presentation. And then lastly, we do appreciate and strongly encourage your questions. However, please hold your questions until the end, or feel free to post them in the chat as they come up, and Dr. Duarte will answer them at the end of her presentation. And now I have the privilege of introducing today's speaker. Dr. Cassandra Duarte is a second-year hematology-oncology fellow with an interest in malignant hematology. She went to the Warren Alpert Medical School at Brown University and matched at the University of Colorado for her internal medicine residency. She was selected to serve as a chief medical resident for the Internal Medicine Residency Program. Dr. Duarte plans on pursuing a career as a clinical trialist in the field of malignant hematology upon graduation. Thank you, Dr. Duarte, for being here today. I will stop sharing my slides so that you can pull yours up, and we can begin whenever you're ready.
Awesome, thank you. It's nice to meet everybody. Thanks for having me. Just to review the poll, it looks like most individuals on this call have not taken care of someone with acute leukemia. So thanks for answering that. It just helps me sort of orient who my audience is and maybe how in depth I have to get in terms of AML treatment. And so I'm going to end the poll. I'll share the results with you all so you can see it too. And I'll stop sharing so I can clean up my screen. All right. So I'm going to get into the meat of our presentation for today. Feel free to put questions into the chat. I'll try and answer them all at the end. And then if I don't get to your question, please feel free to add your email address. And I can always email with you afterwards to help answer that. And so, like it was mentioned, I'm one of the hematology oncology fellows. I've been at CU for a long time since I did residency and my chief resident year here. And just as a word of warning, I am on service at Denver Health today. And so I've told everybody that I'm busy for this hour, but if anything acutely comes up clinically, I may have to just duck out for a minute and then come back and resume. But hopefully that should not happen. And so my talk today is titled Socioeconomic Status as a Mediator of Overall Survival in Acute Myeloid Leukemia, or abbreviated as AML. In terms of disclosures, this research is funded by a research grant from Flatiron Health. And so I'm just making sure everybody is aware of that. And so let's talk a little bit about AML, just to make sure that we're all on the same page in our audience. And so AML is an aggressive hematologic malignancy that's due to inappropriate clonal proliferation of myeloid blasts or immature myeloid cells. We diagnose it either by doing a bone marrow biopsy and looking at the aspirate, or you can do it on flow cytometry. You have to have at least 20% blasts on either of those tests. Or if somebody has certain cytogenetic markers, even without achieving that blast percentage, we still say that they meet criteria for AML. These are what blast cells look like, so that's what we're looking for underneath the microscope when we do these procedures. And you can see here that outcomes are generally very poor for AML. And so overall, the 5-year overall survival is estimated at around 30-31%. You can see here in terms of different age breakdowns that generally speaking, children do very well, greater than 70% 5-year overall survival. But as we go up in age, for individuals who are 60 years old or greater, the 5-year overall survival is estimated at less than 10%. And so a pretty dismal prognosis in most of our patients that are older that are diagnosed. In terms of the epidemiology, there's about 20,000 new diagnoses every year, about 11,000 deaths. The average age of diagnosis is about 68 years of age. And so, from the prior slide, that means most patients are not doing very well with this diagnosis. In terms of why people develop AML, so it can be de novo, a mutation that our cells pick up over time as we age. There are some genetic factors, or mutations rather, that can predispose someone to AML. And so things that we see commonly are There are mutations in 2 genes, one called RUNX1, one called DDX4. Different environmental exposures can also predispose someone to AML. So like rubber workers can be predisposed to it, people who work with benzene or ionizing radiation. And then lastly, there can be treatment-related AML. So if somebody has had a prior cancer, they get radiation or they have some sort of chemotherapy, they can also end up developing AML down the road due to side effects of their prior treatment. In terms of clinical presentation, so how do these people present? Only about, I think, a handful of you all have taken care of someone with AML. And so all symptoms are truly due to disruption of normal hematopoiesis. And so if the body is not making the normal cells that it should be, patients can have lots of problems. And so if you're not making the appropriate number of neutrophils, white blood cells, they can struggle with infection. If they are not making red blood cells, they can have fatigue from anemia, and then they can always have bleeding complications from thrombocytopenia or low platelets. The other thing that we worry about in AML is complications due to leukostasis. And so as the percentage of blasts rise in the peripheral blood, you can sort of think about it as someone's blood becoming extremely thick, and these immature cells are clogging up their normal vasculature. And so people can have issues with their pulmonary status. They can have stroke-like symptoms. They can have, coronary events that would look like an MI, and all of that could be due to leukostasis, so basically poor blood flow due to all of these immature blood cells. And then lastly, the things that we worry about for individuals with AML, we keep an eye out for things like DIC and TLS, as they can have pretty severe coagulation abnormalities and also metabolic abnormalities with their usually some combination of these symptoms that bring them to medical attention. In terms of prognostic factors for AML, so here are a list of things that are associated with poor prognosis for individuals. We've talked many times about age being a poor prognostic factor. Their cytogenetics can also be very important, and we'll talk more about that in the coming slides. And you can see here, people have treatment-related AML if they have a prior myeloproliferative neoplasm or myelodysplastic syndrome. They might do worse if they don't achieve a complete response after their first line of treatment, and that's generally a poor prognosis. And so let's talk a little bit more about cytogenetics. So this table here demonstrates different risk categorizations for something called the European Leukemia Net risk categorization. So favorable risk category means these patients do better. Adverse means these patients, generally speaking, do worse. And so these are all different mutations that can be present on a patient's cytogenetics. So when we do the bone marrow biopsy or the flow cytometry on peripheral blood, we would look for mutations falling into these categories to then prognosticate which risk category they fall into. I just want to point out one mutation. So this NPM1 mutation will come up again later. And so just to sort of put it in your mind, when patients have an NPM1 mutation without this associated FLT3 mutation, it's generally considered a favorable risk profile. And so just keep that in the back of your mind for later on in this talk. So let's talk a little bit about treatment, broadly speaking. And so the really important thing to remember is that anytime you have a patient with AML, the very first thing that you should think of when you're considering treatment is their medical fitness. So medical fitness is not, how many miles can they run and what sort of exercise can they tolerate, but rather what are their comorbid medical conditions and what is their performance status when they present to medical care. So performance status meaning, are they up and out of bed for most of the day? Are they able to take care of themselves and perform their activities of daily living, or do they require assistance with that? And in terms of comorbid medical conditions, we care a lot about pre-existing cardiopulmonary disease, renal disease, hepatic disease, because these are all things that can come up, in terms of complications of treatment for AML. And so it's very important for us to take a holistic picture of the patient, not thinking just about age or just about what their prior diagnoses are, but really looking at them holistically. The second thing that we think about is their risk stratification. And so what are their cytogenetics? What is their profile of their AML? And so you can see in the table here that if someone is considered medically fit, we usually start treatment with induction chemotherapy. And so that's a regimen called 7+3. 7 days of cytarabine with 3 days of an anthracycline, which might be daunorubicin or idarubicin, just depending on institutional preference. Once someone gets through induction chemotherapy, then we talk about post-remission therapy. And this might look different based on their risk category. So favorable risk patients might just get some consolidation chemotherapy. Unfavorable risk patients would be considered for allogeneic stem cell transplant. And then lastly, we have some targeted therapies that can target these mutations that are listed on the screen. And so those might play a role in someone's treatment plan if they had those mutations present on diagnosis. That's all for medically fit patients. Patients who are medically unfit, and we don't think that they will be able to tolerate, full strength induction chemotherapy, are often considered for treatment with a hypomethylating agent. And so the two most commonly used ones are decitabine and azacitidine. And so they'll be put on those and kept on those sort of indefinitely unless they stop responding or want to come off treatment. And then recently, a lot of work has been done by Dr. Pollier and his colleagues, even here at the University of Colorado, about the introduction of venetoclax in combination with hypomethylating agents. And so I would say that azacitidine or decitabine plus venetoclax has become a frontline therapy for patients who are not fit enough to tolerate induction chemotherapy who have AML. So you'll see a lot of patients here at the university treated with that. And the difference here is that there is no post-remission therapy for those patients because they are kept on this therapy indefinitely until their disease stops responding or until they may decide to come off treatment. Okay, so there's hopefully a good primer in AML for everybody. So we're sort of on the same page when we start talking about the next parts of our presentation. And so I and my mentor, Dr. Maria Meyer, were interested in looking at disparities in AML care. So it's very well known in the solid tumor world that non-white patients often have disparate care when it comes to oncologic diagnoses. And so we wanted to take a chance in doing this research to figure out if those same disparities exist in the AML world. So that's why we did this project. And so just to give you some background information on some research that's been done previously, we know that Black patients have a lower overall survival compared to white patients who are diagnosed with AML. Two studies, one by Bhatnagar and one by Patel, that have shown this. And so some data from their paper, you can see here that the overall survival is much lower and statistically significantly lower for Black patients versus white patients in their study. And they looked at a lot of different factors. They saw that Black race was associated with an increased risk of death when compared to non-Hispanic white patients with a hazard ratio of 1.1. This difference persisted even when accounting for other confounding factors. But in this particular study, they saw the difference was not as pronounced in patients who were older than 60 years old. And so it seems to be an issue mostly with younger patients and their patient population. So the second thing is that despite a more favorable cytogenetic risk profile in Black patients, their overall survival is still worse. And so again, from these two studies, they looked at patients with NPM1 mutations. So if you recall from an earlier slide, that means usually a favorable risk disease profile. Black patients with NPM1 mutations still had a worse overall survival compared to white patients with the same mutation. And so you can see the data here as well for this specific population. And then lastly, there have been some studies that show that Black patients and low socioeconomic status patients are less likely to undergo stem cell transplant or receive chemotherapy as treatment for their disease. And there's some data that shows that induction chemotherapy is given at a similar rate for these populations, but that outcomes are still worse for Black patients. And so this is sort of where we're beginning our project and the data that we have, and this is what has inspired some of our questions in this data set. And so there exists a knowledge gap. Like, why are we investigating this if I've already told you that we have some of this data from these prior studies? One important thing is that Flatiron Health, so the institution that has collected this data, they have a wealth of community cancer centers represented in their data. And so I think that's something that's very important for us to recognize. Most patients in the United States who receive oncologic care actually get care in community centers and not in academic centers. And so oftentimes when academic work is pursued, it's done at an academic hospital. And so we're sort of getting a skewed picture of patients who are being presented. And so I think it's key that we have a holistic patient population that's represented. We also wanted to comprehensively examine multiple demographic factors and first-line treatment outcomes. And so, although work has been done looking at molecular findings for patients and their outcomes and first-line treatment outcomes based on demographic factors, we wanted to sort of examine all of this very comprehensively in a data set that included patients from community cancer centers. And to clarify, Flatiron does also include academic centers, but the inclusion of community centers is what makes this data set unique. And so I'll walk you through our project aims. Our primary outcome for this study was to look at overall survival stratified by race, ethnicity, gender, and socioeconomic status for the patient population. And we had multiple secondary outcomes that we wanted to look at, which I'll list up here. One caveat is that we recently obtained this data from Flatiron Health, so the presented analysis that I'll go through today is not, the complete analysis. We still have a lot of work to do, and I'll tell you more about where you can, hear more about our final analysis at the end of this presentation. So just to FYI you that we will not hit every single secondary outcome that's been listed on the slide, but we'll get through a decent portion of them. So in terms of our methods, when we were querying the Flatiron database, our inclusion criteria had to be that someone was diagnosed with AML via bone marrow biopsy. They had to be at least 18 years old. And then in terms of exclusion criteria, we didn't include patients who had treatment-related AML. We didn't include patients who had acute promyelocytic leukemia. If there was missing information, we didn't include them. And they had to have at least 2 months worth of data for us to be able to examine them. Data collection started from the earliest entry into the Flatiron database until June 30th of 2022 as our cutoff. And then just a word on the socioeconomic status variable. So this is actually a variable that Flatiron Health has created, and it was created based on data from the American Community Survey using census block information. And so what they did was they took a variety of different parameters like income, home values, et cetera, that are listed there, and they assigned a quintile, so a score of 1 being the lowest socioeconomic status to 5 being the highest status, and they assigned a quintile to patients based on their address. And so when you see that variable presented later, I just wanted you to know sort of what it meant and how it was made. So let's jump into some of our demographic data. And so we'll walk through this. In terms of our total patient population, we had just over 3,000 patients, so 3,338 total that were included in this data set. You can see here that overall, in terms of the age of our population, we're consistent with prior known data around the average age of diagnosis for AML. We're right at 68. You can see here that our Asian patients were slightly younger in addition to our Black patients compared to our white patients or patients who identified as another race. In terms of the age breakdown, you can see here that our patient population is overwhelmingly elderly in the realm of AML. So 70% of our patients were 60 years old or greater in terms of the entire population. You can see that there's a little bit of difference between our Asian and Black patients. They had a slightly younger predominance, but for our white patients, again, it's about 70% that were greater than 60 years old. In terms of the breakdown between male and female gender, this is also consistent with prior known data. So AML is more often seen in male patients than female patients, and the trend continues here, about a 40-50 split between female to male patients. Next, you can see the breakdown of races in our patient population. And so just one thing to draw your attention to is that we have a very small Asian population here in the study. So only 71 patients, about 2%. And so just keep that in the back of your mind as we go through our data, that this is a quite small population for Asian patients. We have about 8% Black patients, and then the rest are predominantly white. And then looking at ethnicity, so either Hispanic or Latino or non-Hispanic or Latino, you can see that most of our patients did not identify as Hispanic or Latino. About 6.5% of our patient population identified this way. To continue on to our next set of demographic data, you can see ECOG, so that's a measure of performance. 0 means that someone is totally unaffected by their disease. 5 means that they are dead from their disease. And so it's sort of a graded scale from 0 to 5. You can see that obviously we have no 5s included because they wouldn't have been captured in the data set. You can see here that most patients, though, fall into an ECOG of about 0 or 1 for our total patient population. And this is important again as we think about that medical fitness and what treatments patients might be able to tolerate. And then the last thing here on the slide is that SES quintile. So as a reminder, 1 is lowest SES, 5 is highest. I think that the interesting things to point out here is that for the total patient population, we have a fairly decent spread with a slight predominance towards the level 3 and level 4. But if you look at our Asian patients, they were more consistently in the high socioeconomic status. And likewise, if you look at our Black patients, they were more likely to fall into the 1 through 3 measurement. And for our white patients, it was a pretty even spread across the socioeconomic status quintiles. The last thing that we'll go through is a little bit of data in terms of the European leukemia risk net score. And so the one thing to point out here is that our patient population predominantly had an adverse risk profile, so 63.5%. And this was true across the different races that were represented in our population. In terms of looking at first-line treatment, and so I wanted to point out, this, and I'll sort of walk through it now because this will consistently come up in our data. So this first line here is azacitidine or decitabine. So that's somebody getting just a single hypomethylating agent. And so as you can imagine from our conversations earlier, this is usually saved for somebody who is not fit enough for induction chemotherapy and is not even fit enough for venetoclax plus a hypomethylating agent. And so you can see here that about 20% of the patients were put on a single agent therapy. The next line down looks at venetoclax plus a hypomethylating agent. So something that is standardly considered first-line therapy now for patients who are medically unfit for induction chemotherapy. You can see here for the total population, again, a little bit lower, 15% received aza-ven or venetoclax and decitabine. Next, we have our cytarabine plus daunorubicin or idarubicin. So that represents standard induction chemotherapy. And about a quarter of patients, give or take, about a fifth, had gotten this treatment regimen. And then the last line here is none of these. And so I just wanted to clarify that this doesn't mean that the patients did not receive treatment. We did not include any patients who did not receive treatment in this analysis. And so if somebody falls into the none of these categorization, that means they received a treatment other than the 3 options listed here. And so that might have been a different medication, a clinical trial. We just sort of grouped them together to sort of show how outcomes might be different. And I think this is a potential area for future research as well. Lastly, we've looked to see has anybody received an allogeneic stem cell transplant. And so you can see here, unsurprisingly, that a majority of our patients have not received a transplant. Around 3/4 of the population did not undergo transplant. And so we did the same sort of breakdown of demographic factors, looking at ethnicity, so Hispanic, non-Hispanic as well. And I won't belabor these points. A lot of the information, is the same between the breakdown in race and the breakdown in ethnicity. But I just wanted to put the data up to sort of be transparent and show. Again, as a reminder, we only had about 6.5% representation of Hispanic or Latino patients in this study. So it is a small percentage, but I think it's still important for us to share this information because if we don't share the information, then I think we're doing sort of a disservice to the academic community because some of this might inspire future research questions. And so just in the spirit of transparency, I'll put it up for you all to look through. Then we had the same thing in terms of risk profiles, first-line treatments, and stem cell transplant. And really none of the values are all that different from the previous breakdowns that we had with race. So as a summary of our demographic information, we had a predominantly white population, predominantly non-Hispanic or Latino, a slight predominance towards male patients, which again is unsurprising. We do have an older population with 70% being greater than 60 years old. Overall, a decent spread through the socioeconomic status quintiles and predominantly adverse risk AML in terms of their European leukemia net score. So let's get into our primary outcome, which is overall survival. And so what I'll do is I'll talk about the entire population, and then we'll talk in detail about each of the demographic factors that we went through. And so with a median follow-up of just over 1,200 days, median overall survival was about 478 days for the population as a whole. So about a year and 3 months, give or take. So we broke this down by race. And so looking at the different races, you can see here that the spread of overall survival is pretty similar between the races. There's no significant difference in terms of our p-value. And then just to sort of prove it, I've included our Kaplan-Meier curve. You can see here that all of the lines are overlapping, they're intersecting. There's no statistically significant finding when we look just by race. And so, we'll talk about interpretations of this, but a little bit surprising given the previous research that we know in this field. So we know how important age is in terms of outcomes for AML. So we said, okay, what if we look at race and we split it up by age? We know younger patients are going to do better, older patients are going to do worse. And so here, we've broken down our data into 3 separate age groups: 18 to 39, 40 to 60, and then greater than 60 years of age. And so the finding here is that there's a trend towards significance with our younger patients. You can see here our p-value is 0.06. Again, I'll point out that our Asian population is quite small, and so they had the lowest overall survival, but again, not very strong representation once we sector out the data this way. For Black patients, you can see here that their overall survival was just over 1,000 days, and the overall survival was not reached for our white patients. And so this is our Kaplan-Meier curve for this patient population. I've labeled our white patients and our Black patients, so you can certainly see here that there is a difference between overall survival for white young patients with AML versus Black young patients with AML, though it is not statistically significant at this time. There could be a trend towards this. So for our data set, race alone was not a significant factor in terms of mediating overall survival. However, there appeared to be a trend towards significance when we looked at race stratified by age groups, with younger Black patients having a lower overall survival compared to younger white patients. And this is something that had been seen in the literature before. So let's talk a little bit about ethnicity. So we had broken up our patient population into Hispanic or Latino versus non-Hispanic or Latino. And you can see here that there is a statistically significant difference in overall survival based on ethnicity. And so I think even though numbers might be small, it's important for us to share this information. We do have some colleagues at different institutions that have found similar things, but have not published this data. And so I think it's important for us to further investigate as an academic community to figure out how or why this difference might be coming about. And so we also looked, not just by ethnicity, but also by race. And so looking at Hispanic white versus non-Hispanic white patients, we saw this significance continued. And the Kaplan-Meier curve on the right is representative of that. Now, unfortunately, for our Hispanic Black and non-Hispanic Black populations, the sample sizes were too small to effectively compare those two groups. And so we would just need more patient representation in order to comment more thoroughly on whether or not there's a difference there. And so we can't really speak to that, just given the current limitations of our data set. And again, so we know that age is important. If we look at overall survival by ethnicity and then stratifying by our age groups, you can see here that there's no statistically significant difference in the different age groups. Perhaps a trend towards significance are patients who are greater than 60 years old for Hispanic or Latino ethnicity, surviving longer, but again, not statistically significant. And we did this analysis looking just at our white Hispanic and white non-Hispanic patients, and there was no statistically significant results. So in terms of interpretation, looking at ethnicity, overall, Hispanic and Latino ethnicity was associated with improved overall survival, even when accounting for white race. When controlling for age, it was not statistically significant, but there seems to be a trend towards significance in our older patients. And then just as a reminder, overall, a small Hispanic or Latino population, this is still a significant finding. And so next we'll talk about gender. And so here, we compared male versus female gender, and you can see that there's a statistically significant difference with female patients on average doing better, surviving longer than male patients. And you can see that also in the Kaplan-Meier curve here. So females are represented by the blue line, males are represented by the red line. You can see those curves separate very nicely, as we look at overall survival. And so this was significant. And we did the same thing, looking at breakdown by age. And so you can see here that there was a statistically significant difference for older patients. So again, female patients who are older surviving longer than male patients who are older than 60. And then again, perhaps a trend towards significance for middle-aged patients. And so this graph demonstrates our older patients, 60 or greater. You can see again, those Kaplan-Meier curves, lines do not intersect, and female patients are surviving at a higher rate than male patients. And so again, to summarize, female gender associated with improved overall survival, and this is also statistically significant for older patients, a trend towards significance for middle-aged patients. So let's get into our last demographic factor, which is socioeconomic status. As a reminder, the SES quintiles go from 1 to 5, with 1 being the lowest income and 5 being the highest. And so if we look at sort of breaking up the patient populations into either low income, so SES value of 1 or 2, a middle income with a value of 3, or a high income with a value of 4 to 5. You can see here that if we compare all 3 groups, there's no statistically significant difference. The p-value is 0.06. You can see here on the right-hand side, these curves are close, some of them overlap, and so it's not statistically significant. Now, if we ask ourselves and say, what if we compared low versus high socioeconomic status as opposed to comparing a gradient of incomes? You can see here that if someone is a low SES quintile, 1 or 2, versus a high SES quintile, 4 or 5, that there is a difference in terms of overall survival. Now it's about 483 days versus 516. I think that although this is statistically significant, it's important for us to ask, does a difference of about, 1 month, is that clinically significant? We can talk more about that at the end, but statistically speaking, socioeconomic status does appear to be a mediator of overall survival. And for the graph on the right, the higher income patients are in red, the lower income patients are in blue. You can see here the separation between those. And then, of course, because we know that age is important, we did the same analysis again, looking at our age categorizations, and the 2 p-values that are listed. The first one is for comparing all 3 groups. The second one is comparing just the 1 and 2 versus 4 and 5. And so you can see here that the older patient populations did have a statistically significant difference when we looked at overall survival stratified by socioeconomic status and age group. I can put that graph up too for you all to see. So again, higher income patients who are older doing better than lower income patients who are older. And so it seems like higher socioeconomic status quintile is associated with a statistically significant improvement in overall survival, which holds for elderly patients as well. So to summarize our demographic factors, it seems like race alone is not a significant factor in overall survival, with perhaps a trend towards significance for our younger Black patients versus younger white patients. Hispanic and Latino ethnicity is associated with improved overall survival, even when accounting for race. Female gender is associated with improved overall survival, and then a higher socioeconomic status is associated with improved overall survival as well. And so all of this data here has to do with our first primary outcome, so the main reason why we had done the study. And so age seems to be the biggest factor as we looked at all of this. And so let's just take a deeper dive into that. And so what we did was looking at our entire population. We broke out our age groups, and you can see here, unsurprisingly, based on previous data that we know about AML, that individuals who are younger generally tend to do better with this diagnosis of AML. And so it is extremely unsurprising that the patients who fall into the 18 to 39-year-old range, had a overall survival, marked in 2,700 days versus our older patients who are just at about 1 year. And you can see here for the Kaplan-Meier curve, and those curves are all extremely separate. Our older patients are the ones in black. They clearly have the lowest overall survival as time goes on. Okay, so we've talked about our primary outcome at this time. Now we can dive into some of our secondary outcomes that we have analyzed at this point. And so what we wanted to do was look at overall survival by first-line treatment. And so, we know and hypothesize that if someone is strong enough to receive induction chemotherapy, then ideally they should get that because it's associated with the longest overall survival. And so we wanted to compare these 3 first-line therapies, so a single agent hypomethylating agent, venetoclax plus a hypomethylating agent, or induction chemotherapy, which is a cytarabine plus daunorubicin or idarubicin. And then just remember that none of these means they received some sort of therapy. It was just different than the 3 listed there. So clinical trial or another medication. And so you can see here, if you look at the graph, that the blue line represents induction chemotherapy. These patients are clearly doing much better than any of the other treatment options. What you can then see is that patients who received a different treatment actually did the second best. So maybe a clinical trial. The brownish black line here represents venetoclax plus a hypomethylating agent, and so they did the third best. And then, as we know, a single agent hypomethylating agent is represented in the green line. Those patients did the worst compared to the rest of the folks. And so this is a significant finding, although an unsurprising one. We know this. And so let's look a little bit about first-line treatment and age breakdown. Again, we know that age is an important prognostic factor for individuals with AML. And so the significant finding here is that for our middle-aged patients and for our elderly patients, you can see that there is still a significant difference between folks who receive induction chemotherapy and folks who receive either a hypomethylating agent alone or a hypomethylating agent with venetoclax. And so some of these numbers are tremendously different. So, for our middle-aged patients, about 400 days if they receive just a hypomethylating agent alone versus 1,400 days if they're on induction chemotherapy. And so just wanted to point out the striking difference and sort of the difference that first-line treatment really does make in terms of outcomes for patients with AML. If you look at our older patients, this trend holds true. So just because someone is 60 doesn't mean that we should not be offering them induction chemotherapy. Again, it's going back to that medical fitness question. You can see here patients that are older but that can tolerate induction chemo have an overall survival of around 2 years versus just under a year if they're put on a single agent hypomethylating agent. So we also looked at first-line treatment and broke it down not only by first-line treatment, but by race. And so in the first column, and just as sort of a reference point. And then we have it split out by our Asian patients, Black patients, and white patients. And so the p-values that are presented are comparing within the race between the lines of treatment. And so you can see here that the same information holds, like, Asian patients who are put on induction chemotherapy do better than patients who are on single agent therapy. And this holds across the different races that were examined. And so I'm just sort of pointing this out. It's statistically significant for all of them. And so once again, confirming that induction chemotherapy appears to be best if a patient could tolerate it. We can also look at the same outcomes, looking at first-line treatment option plus ethnicity. And so again, the findings here are very similar, proving that first-line treatment with induction chemotherapy is still the preferred option if possible. Doesn't seem like there's a difference in terms of different ethnicities responding differently to first-line treatments. And so now let's look at first-line treatments and socioeconomic status. And so we knew that socioeconomic status was mediating overall survival in our total population. So what if we look at first-line treatment options now? You can see here, broken it down into the low socioeconomic status, middle, and high for the table. And so the quintiles are assigned there in the parentheses. If we look at the outcomes for this, we can see here that patients who receive venetoclax and a hypomethylating agent, if we look at low versus high socioeconomic status, there's really no statistically significant difference there. And so, it's important finding that someone's socioeconomic status doesn't predict how they'll respond to venetoclax plus a hypomethylating agent. We also looked at induction chemotherapy and compared the outcomes of low versus high socioeconomic status patient groups. And again, there was no statistically significant difference there. And so it seems like, at least in our patient population, that when given the same treatment options, there's no difference in terms of outcomes for these patients. You can sort of see visually, it may seem like 994 days for induction chemotherapy for low SES patients seems different than high SES patients at around 1,200 days. But statistically, when we compare them, it's not statistically different. So in terms of our interpretation for this, 7+3 or induction chemo is associated with the best overall survival. And this was true across age groups, race, ethnicity, and SES. When controlling for first-line treatment in SES, there was no difference in terms of the outcomes seen. And so perhaps challenging to some of the prior data that we discussed earlier in this presentation. So we've talked about our primary outcome, we've talked about first-line treatment options, and so let's jump into our next secondary outcome that we've had time to get through. And so the next thing that we looked at was time to second-line treatment by someone's first-line treatment. And so, in our minds, we were thinking, is there a difference in terms of how quickly someone progresses through their first-line treatment in terms of needing a second-line treatment? And so I'll talk through this a little bit more sort of clearly, because I think that there's some nuances in terms of how to interpret this data. And so for our study population, the time from first line to second line treatment was about 280 days. You can see here that the time for a single hypomethylating agent, so azacitidine or decitabine, was about 418 days, and about 800 days, give or take, for venetoclax plus a hypomethylating agent. And then for cytarabine and one of our anthracyclines, daunorubicin or idarubicin, it was at 243 days. I'm sorry, my graph is covering up part of that line. And so you might be asking, why is it so much shorter for patients who are on cytarabine and daunorubicin or idarubicin? If they're getting induction chemotherapy, I thought they did better. So why is their time to second treatment shorter? I think that part of it is, for patients in this category who are fit, their next line of treatment would be an allogeneic stem cell transplant for consolidation. And so it might have been that they were, teed up for transplant versus azacitidine alone or decitabine alone or venetoclax plus an HMA. Those patients don't really have a next line of treatment that they have to get to for consolidation therapy. And so it makes sense that they're on this treatment for longer because we really use it more in like a maintenance type setting. They stay on it until it's no longer working or they don't want to be on it. And so even though this is significant in terms of the differences between time to second line treatment, it makes sense clinically in terms of why the data looks like this. And so we looked at this again, broken down by first line treatment and by age group. And you can see here that's a statistically significant difference by age and by treatment line. And again, I think that the things that sort of stuck out to me is, looking at our younger patients, we did have some younger patients who were on single agent therapy, which there must be other reasons why these individuals were on this instead of getting induction chemotherapy, but very short, had only 48 days before they progressed to another line of therapy. And so some of this might have been maybe they were initially diagnosed at a center and then sent off somewhere else for a clinical trial or for more advanced care. I'm not sure, in terms of the granular details of that. You can see here that the time wasn't reached for venetoclax plus a hypomethylating agent. And then for induction chemotherapy was just around a year for our younger patients. None of these are all that surprising in my mind. And then if you look at the middle-aged and older patients, you can see that this trend, holds true but between these two. So patients who are on azacitidine or venetoclax plus azacitidine and decitabine tend to be on it for a while. We know that it's a well-tolerated therapy and people do pretty well on it. And then again, people who are on induction chemotherapy were on this for a shorter period of time before their next treatment compared to the sort of more maintenance style therapy. So we also looked at time to second line treatment and we split it out by race, ethnicity, gender, socioeconomic status. And there's really no difference when we broke it down in these ways in terms of time to second line treatment. And so it's important for us to acknowledge that these didn't seem to be affecting the time to next treatment. So interpretation, 7+3 is associated with the shortest time to next line of treatment. So as we talked earlier, presumably a transplant if the patient is fit enough. And then venetoclax plus a hypomethylating agent is associated with the longest time to next treatment, which makes sense. It's something that people stay on indefinitely. It's a well-tolerated medication regimen. And so none of this information was really all that surprising to us. So here's what we've gone through so far in terms of our analysis. And so as you can see, we still have a couple of things to follow up on in terms of our secondary outcomes that we just haven't had time to do our analysis for yet. We were hoping to get this data earlier, but we did what we could with the data once we got it from Flatiron. And so let's talk a little bit about how our study adds to the knowledge base that we have so far in terms of disparities in AML care. So again, as a reminder, race alone is not a significant factor in mediating overall survival for our study. And so this is a new finding compared to prior research. I talked earlier about how we knew that Black patients had worse overall survival, especially Black younger patients, even if we controlled for cytogenetics with that favorable risk NPM1 mutation. And so this is different in terms of this patient population. We also saw that Hispanic and Latino ethnicity was associated with improved overall survival, even when accounting for race. And so this is also a new finding compared to prior research. And so the study cited here had looked at AML survival for Hispanic patients and saw that they were usually diagnosed at a younger age and had worse survival compared to non-Hispanic patients. But you can see here in our study that that didn't seem to be the case. So patients who were identifying as Hispanic or Latino actually had improved overall survival. Female gender is associated with increased overall survival. This is consistent with previous findings, and so the paper cited here has also discussed that. And then higher socioeconomic status is associated with a statistically significant improvement in overall survival. And this also confirms some previously discussed findings as well. And so, based on the secondary aims that we've analyzed so far, 7+3 or induction chemotherapy still remains the best choice for treatment if a patient can tolerate it, based on the information that we have, regardless of ethnicity, race, gender, etc. Venetoclax and a hypomethylating agent could be changing the game for medically unfit patients. And so, I think it was interesting to see that for many of our patients, and especially in an older patient population that we had in this study, still had good overall survival, even if they didn't get 7+3. And I really wonder if it's because, the introduction of venetoclax with a hypomethylating agent is a fairly new treatment regimen for patients with AML who are not medically fit to undergo induction chemotherapy. And so part of me wonders if the data that we had previously showing that, differences didn't hold for older patients, maybe some of that is going away because older patients are being put on, venetoclax plus a hypomethylating agent and actually doing pretty well on it. So we might be erasing some of the differences that were seen previously for older patients. And the other important thing to note is that socioeconomic status, the overall mediator of overall survival, didn't seem to be statistically significant when we looked at overall survival by treatment line. And so I think more work needs to be done to figure out, is there something different about the different SES populations that we have? And so one thing that I think that we really need to delve into is looking at things like molecular markers. We have information on that for these patients to see if their molecular status and cytogenetics might be the thing that's predicting the difference, if it's not, due to what they got for treatment or something of that nature. And so in terms of future plan analyses, just to sort of summarize, we have these secondary outcomes still left to analyze. And then, like I mentioned, we'll be looking at molecular status and outcomes, and particularly around folks who have that NPM1 mutation. There's a lot of research going on to see if those patients, respond differently to first-line treatments. And so that's something that we're hoping to analyze further, and we'll hopefully have more information to look at in a little bit more detail. So that summarizes most of our findings. I just wanted to give some brief acknowledgements. And so a big thank you to Flatiron Health for accepting our proposal and giving us a research grant to look at these questions. My mentor, Maria Amaya, has been absolutely wonderful to work with and has been, truly a pleasure to sort of work with on this project and has inspired me to look at this research. I would not be here without our statisticians, Diana and Grace. They have helped out tremendously with analyzing all of this data. And then I would just like to thank the leukemia groups of Drs. McMahon, Gutman, Pollier, and Jordan. Dr. Bowles is my program director, and my co-fellows have all been very supportive in this last year and a half of fellowship. And then obviously thank you to all of you for having me as a speaker. And then I'm just sort of putting in a plug. If you have questions, if you want to hear more about research like this, my email address is up on the screen, so feel free to email me anytime. And I'm happy to, hop on a call or exchange emails with you if you're interested in learning more. We have another project that we're working on looking at outcomes for patients who are actually treated here at the University of Colorado. And so I'll be doing a hematology grand rounds on October 24th at 4 p.m., looking at how race and ethnicity influence care here at the University of Colorado for Division of Hematology patients. So if you're interested in this, if you want to hear more, then feel free to take a screenshot of this and join us. And we'll also be in person at the Night Horse Campbell building that day. And so you can go in person or on Zoom. And then lastly, we've submitted data both from the information that I presented today and from this hematology grand rounds talk that's upcoming to the American Society of Hematology meeting, which is happening in December of this year. And so fingers crossed that our data gets accepted. But if it does, please feel free to either look out for us at the meeting with more final analysis on this, or look through their abstract booklet, and hopefully our data will be accepted, and we can show off our final analysis for this. So I will stop sharing my screen so I can see if there's any questions and pause there.